One, please start, ma'am. We are live.
Okay. Namaste and good evening, everyone. A very warm welcome to Euro Onco Insight 2025. We are honored to have you join us for this webinar. We look forward to insightful discussion and meaningful learning this evening. With immense pleasure, I would like to invite program convener Dr. Vikas Asati. He is the Associate Professor, Department of Medical Oncology, Sri Aurobindo Institute of Medical Science, Indore. It's over to you, sir.
So thank you, ma'am, for this introduction, and I welcome you all for this international speaker program session. And in this, we will be having one session by Dr. Robert Jones, and followed by that, we will have a very short panel discussion. We will try to understand what is the role of this drug. And to introduce Dr. Robert Jones is among the top 10% research person in the field of oncology. He is a professor of clinical cancer research at University of Glasgow, and also is a director at Glasgow Oncology Clinical Trial Unit and head of the Cancer Clinical Trial Unit of Scotland Collaboration. He was the past chair of UK NCRI Bladder Renal Cancer Research Group and Advanced Prostate Cancer Subgroup, and he has a special interest in prostate cancer, bladder cancer, and renal cell carcinoma. So over to Dr. Robert Jones. We welcome you, sir.
Thank you very much for that kind introduction. Let me share my slides. Here we go. So hopefully you can all see
Yes, sir.
my slides there. So yeah, so thank you for your kind introduction, and it's a huge pleasure to be in India. I'm actually in Chennai, so we're not seeing you in person. This is my first visit to India. Just for those of you who aren't familiar with the geography of the United Kingdom, I'm from Glasgow, which is up here in Scotland. This is Glasgow University, where I'm employed. I don't actually work in that rather fine building. It would be a terribly impractical hospital, I suspect. But this is Glasgow University, with Glasgow stretched out behind it. If you've not been to Scotland, you must at some point, because Scotland's a very beautiful country. It's the best bit about Scotland is its wild places, and the interplay between the mountains and the sea, as shown here. These are my disclosures. We're here largely to focus on enfortumab vedotin, which is a relatively new drug to all of us in the field of urothelial cancer. But I'm going to take you through 5 steps, really. I'm going to start off with a very brief historical perspective on the treatment of advanced urothelial cancer. Then we're going to go into a bit of depth about the EV301 trial, which underlies its current regulatory approval, at least in India. Then we're going to talk about a little bit of real-world data, bringing this into how these results translate into clinical practice, and then just a little bit about the next steps for this drug in this disease, and then we're going to follow that with some case discussions to talk a little bit about the practical management of the drug as well. So first of all, a historical perspective. So cisplatinum-based chemotherapy has been the cornerstone of advanced urothelial cancer for a very, very long time. And of course, until relatively recently, it remained really the only proven therapy in advanced urothelial cancer. And it's worth remembering that the history of this isn't terribly glorious. There was a trial of this 4-drug combination called MVAC, which is methotrexate, vinblastine, doxorubicin, and cisplatin, compared with monoagent cisplatin some 33 years ago, which showed that combination chemotherapy was superior to cisplatin alone. But we don't tend to use MVAC. MVAC was quite a tough-going regimen. And then there was a trial comparing gemcitabine given in combination with cisplatin against this MVAC regimen, that actually failed to show that gemcis was superior to MVAC. But what it did show is there was really very little difference in terms of survival outcomes anyway. And it also showed that the gemcis was better tolerated than MVAC. And so really, since then, gemcis has really been the mainstay of treating apologies, my screen's just doing some funny things, has been the mainstay of treating advanced urothelial cancer across the world, really. But of course, we also know that many patients, arguably most patients, I think in my practice, about half of the patients I can give any chemotherapy to, I can't actually give them cisplatin for one reason or another. And so we know a large proportion of patients are unsuitable for cisplatin. And so in that group of patients, we tend to use gemcitabine in combination with carboplatin. And this was really established in this EORTC trial led by Maria DeSantis, which compared gem-carbo with a carboplatin-based version of MVAC, essentially. And this again showed that these were giving similar results with actually quite good outcomes, the response rate of 41% to gem-carbo in this trial. And it's also worth remembering that even in the days when all we really had was platinum combination chemotherapy, for some patients, the average survival outcomes were around about the 12 to 18 month mark. There were some patients who were long-term beneficiaries from this treatment. So these are just some mature follow-up overall survival data from a couple of the trials that had been done historically, and you can see that 4 and 5 years of follow-up, there's about 1 in 8 patients are actually still alive, and so anybody who's been treated metastatic urothelial cancer in a mature practice would always have a handful of patients who are actually long-term survivors with just one line of platinum-based chemotherapy. And it's easy to forget that when we're talking about the advantages of particularly immunotherapy, I think. And then, of course, there was then really no progress for about 25 years, at least in terms of improving survival outcomes. And this was in 2017 that we saw the first results of the positive randomized phase 3 trial of immunotherapy in the second line. And this was one of a couple of trials, of which this was the only strictly positive trial. This is the Keynote 45 trial, which randomized patients who had previously had platinum-based chemotherapy to either a dealer's choice of taxane, paclitaxel, docetaxel, or a drug called vinflunine, and that was the control arm, or to monoagent pembrolizumab, which was the experimental arm. And this was a positive trial for overall survival. And these are the data shown here. So you can see that that on mature follow-up, the hazard ratio there for survival is 0.71. And then, of course, the next trial that came along was the Javelin 100 trial. And certainly this is the trial which has really defined my current practice in advanced urothelial cancer. This is a slightly different setting rather than the second line settings. So in that previous trial, the patients had the platinum-based chemotherapy and then progressed and then went on to the immunotherapy. In the Javelin trial, this is for patients who had not progressed during or at the end of platinum combination chemotherapy. But rather than waiting to progress before immunotherapy, the patients went straight on to immunotherapy. So avelumab being a PD-L1 targeted antibody in the maintenance setting. And this showed, I guess, the biggest survival gain we'd seen yet in terms of advancing overall survival in advanced urothelial cancer. Whether you can see at the median there, it's an 8.8 month improvement in survival, reflecting a 24% reduction in the risk of death. And so this fairly rapidly became the standard of care, that patients would have platinum combination chemotherapy, either gem-carbo or gem-cis. And for those who had not progressed, so stable disease or response, at the end of treatment, they would then go on to maintenance of avelumab. But it still left us with a problem as to what then to do in patients who had failed both platinum combination chemotherapy and immunotherapy. Now, prior to all of this, in that 25-year vacuum when we really made no progress, there were countless trials of other agents, mainly cytotoxic drugs, in the second-line treatment arena. And there were no clear winners. There were no positive randomized phase 3 trials. But I think that the class of drugs which had the most activity seemed to be the taxanes. This is just one example of what is a randomized phase 2 trial. Actually, it was a randomized phase 2 trial comparing paclitaxel with pazopanib. It was a negative trial, but I guess what it does show is that maybe if pazopanib is the yellow line there, if pazopanib is doing nothing at all, maybe the taxanes were associated with at least a trend towards a survival gain. But response rates ranging between 10 and 15% in a whole series of non-randomized phase 2 trials for the taxanes. So this was not, as I say, never proven in a level 1 randomized phase 3 trial. But I think it had become by default the standard of care in patients seeking further treatment after failure of platinum, and therefore it became the standard of care in patients who had now failed platinum chemotherapy and immunotherapy. But then this takes us to enfortumab vedotin. So enfortumab vedotin is an antibody drug conjugate. For those of you who are unfamiliar with the concept of antibody drug conjugates, it's a monoclonal antibody against a cell surface antigen of interest, in this case Nectin-4, which is found on the surface of most urothelial cells. And that is conjugated with this linker, the yellow bit there. It's conjugated to an inactive cytotoxic called monomethyl auristatin E, and that's a spindle poison. And so when you give the antibody drug conjugate, it selectively binds to the surface of urothelial cancer cells, because most cells in the body do not express significant levels of Nectin-4. The drug is then internalized in the normal physiological way inside the urothelial cancer cell, where it is then undergoes proteolysis in the normal physiological proteolysis, breaking down the antibody, breaking down the linker, releasing the now activated monomethyl auristatin E, which has a cytotoxic mechanism of action within the cell, targeting the microtubules. So it's like a Trojan horse approach. So a little bit about Nectin-4. So Nectin-4, as I say, is expressed on most urothelial cells and in nearly all urothelial cancers. It tends to be more heavily expressed in cancerous tissue than normal urothelial tissue. And that's the target for the antibody. On the right, there are some data from an earlier phase 2 trial of enfortumab vedotin, and really just illustrating that the level of expression of Nectin-4 doesn't seem to be particularly important, because you can see in the responders there versus the non-responders, there's really not much difference in the levels of Nectin-4. So there's no benefit in testing for Nectin-4. This is a drug you'd give to all of your patients with urothelial cancer. So Nectin-4 doesn't seem to be predictive of the effect of the drug, despite it being fundamental to its mechanism of action. So this is the EV301 trial. So this is for patients who had urothelial cancer and had to have progressive disease after failing a PD-1 or a PD-L1 inhibitor, and they had to have had prior platinum-containing chemotherapy and of reasonable performance status. And patients were randomized between enfortumab vedotin, the new drug, which was is given days 1 and 8, and so days 1, 8, and 15 of a 4-week cycle, compared with a pre-selected physician's choice of those three drugs I mentioned earlier: docetaxel, paclitaxel, or vinflunine. Vinflunine is a third generation vinca alkaloid, which is actually licensed, or was actually licensed in Europe in this context, but was never licensed in the USA. And the primary endpoint of the trial was overall survival. This is the distribution, fairly typical. I don't think there's any big surprises here. The median age was 68. It's a little bit younger than the median age of my patient population, and you can see that most of the patients had reasonable prognostic criteria. Remember, the Bellman score is a prognostic score in the second line setting. So that's there are three criteria: performance status, hemoglobin normal or below normal, or presence or absence of liver metastases. And you can see that the majority of patients were of good Bellman risk score. These are the pivotal primary endpoint data. This is overall survival, and you can see that there's a 30% reduction in the risk of death for patients receiving enfortumab vedotin compared to that dealer's choice of chemotherapy. As you can see, that translates through to approximately a 4-month gain in survival at the median. If we look at the subgroup analyses, the bottom line here is that there are no outliers. Fundamentally, most of these subgroups giving very similar hazard ratios, but no statistically significant outliers. So it doesn't enable us to select patients who may or may not benefit from this treatment. If you look at the secondary endpoints, this is progression-free survival. And again, you're seeing a clear separation in favor of the enfortumab vedotin against the chemotherapy. And if we look at overall response rate, so notice the response rate in the control arm there is nearly 18%. That's actually much better than has been reported in most other trials of taxanes in this setting. So the control arm was performing well, but you can see the response rate to enfortumab is high there at over 40%. If we look at the treatment-related adverse events, and we'll go into this in a bit more detail in the second part of my talk, these are the distribution. I guess the ones that are significantly different are peripheral sensory neuropathy, despite the fact that, of course, we know that taxanes cause peripheral neuropathy as well, dysgeusia, and rash. And we'll talk about some of these in a little bit more detail later. If we look at the time to the onset of the events, you can see that that the skin reactions tended to be an early event, whereas the neuropathy tended to be a later event. So in conclusion, enfortumab vedotin was the first drug to show a survival gain after failure of both platinum chemotherapy and immunotherapy. And enfortumab vedotin has demonstrated a manageable safety profile, at least when compared to cytotoxic chemotherapy. So let's move on and talk a little bit about how we translate these trial findings into the real world. And this is a study called the UNITE study. This is a relatively large US-based real world analysis of patients receiving enfortumab vedotin. There were a few patients who'd had enfortumab vedotin in combination with other drugs. This is essentially a monotherapy, a study of monotherapy patients. And you can see if you look at the headline figures, you've got progression-free survival on the left, median was 6.8 months. This compares favorably with the EV301, actually seems to be slightly better than we saw in EV301. Similarly with overall survival, a very favorable comparison, median 14.4 months compared with 12.9 in the trial. And again, the response rate 52%, which again is actually better than was seen in the clinic in the clinical trial. I've selected a few subgroups which I think are of interest here. Actually, in both studies, you were permitted to have variant histology. You had to have, for both studies, you had to have at least an element of urothelial cancer. But in the Unite study, you were allowed to have you only had to have an element of it, and any other variant that was present in the specimen you were permitted in. So you can see the response. These are the response rates in brackets here. So in the pure urothelial cancer patients, it was 58%, but it was 42% in the patients with variant histology. Patients with impaired renal function, again, response rate 40%. Diabetic patients, we'll come to talk a bit about blood sugars in a while, but certainly diabetic patients certainly benefit from the treatment with a response rate of 59%. And then, of course, since this trial came out, we also now have data for erdafitinib as an FGFR inhibitor. And so the question arises, well, do patients with FGFR mutations benefit? And the answer to that is, at least in this study, yes, they do. The response rate in the FGFR mutated patients was the same as in the whole population at 57%. This is just those variant histology patients, and again, you can see there's really seems to be no difference between the pure urothelial cancer patients and the variant histology patients. Just to reflect back a little bit on these are the data from the Thor trial, which of course is that subsequently published analysis of a randomized phase 3 trial in patients with FGFR mutations between erdafitinib and, again, that dealer's choice of taxanes chemotherapy, showing an overall survival advantage in favor of erdafitinib, with a response rate of 45% to erdafitinib, again, compared to a relatively lower response rate to chemotherapy of 11%. But the reason I'm raising this is because the question arises, if you've got a patient who has an FGFR mutation who's had chemotherapy and an immunotherapy, should you give them erdafitinib next, or should you give them enfortumab vedotin? The answer to that question is we don't know, but this is an attempt to answer that question. This is a matched adjusted inter-trial comparison. So this was actually conducted by the Thor investigators. So they've taken the whole published data set for EV301, the EV study I've just described, and then what they've attempted to do is to match patients for predefined prognostic criteria from the Thor trial, so they can reproduce the same population as was in the EV301 trial. So it's a slightly hard to view figure here, but fundamentally the lines of interest are the dotted green line, which is the adjusted erdafitinib group, adjusted to match the EV301 population, where blue is the EV outcomes in that population. And you can see there's very little difference between that blue line, which is enfortumab vedotin, and the dotted green line, which is erdafitinib. So it looks as though these drugs are having a similarly effective in patients with FGFR mutations. So I would infer from this that if the patient has not had EV or erdafitinib and they have an FGFR mutation, then other factors, patient choice, for example, might define which one you give them next. But it certainly doesn't seem to be the case that these patients are more responsive to erdafitinib, have more benefit from erdafitinib than EV, or vice versa. And this is another a final piece of real-world data, which I think are very relevant now, because, of course, at the time the EV301 trial was conducted, chemotherapy followed by maintenance avelumab had not become embedded as the standard of care, because the trial results hadn't come out at that point. And so this is actually some real-world data actually conducted by a French group looking at the real-world outcomes for maintenance avelumab, but they went on to look at what treatment patients received subsequently. So these are patients who've had chemotherapy followed by avelumab and then gone on to other therapies. Now, it's not a pure group, but the blue line here at the top is the patients who got antibody drug conjugates. And for the large part, this was enfortumab vedotin, because enfortumab was available in France at this time. And you can see there that actually patients getting chemotherapy followed by maintenance of avelumab actually have the best outcomes of all, with a median overall survival there of 40.8 months. So this certainly does seem to support that the EV301 trial are very relevant in the current day, where maintenance of avelumab is, at least in my practice, is the standard of care. So in conclusions from the real world data, EV activity as seen in the 301 trial really does seem to be maintained when you bring it into the real world settings. And furthermore, as far as you can from non-randomized data, EV activity appears to be preserved in the subgroups of interest. And so finally, a little teaser, or I suspect reminder for most of you, is that, of course, the story with EV does not stop with monoagent therapy in the third line setting, because, of course, a while ago now, we had the results of the EV302 trial, which was in the first line setting, comparing EV given in combination with immunotherapy, in this case pembrolizumab, compared with platinum-based chemotherapy, and of course we know that this trial had a really stunning result in terms of overall survival, more than doubling overall survival, in fact, in the updated analysis shown here, with the overall survival, the median overall survival there for EVP having a hazard ratio of 0.51, so a 49% reduction in the risk of death. And of course, the response rate in that trial was also high. It was 67%, which lines up nicely with the phase 2 data, actually, compared with 44% for chemotherapy. But maybe the thing that's really driving the activity here is this the duration of that response. And to my mind, these are really striking data, because the median duration of response, if you have EVP, is almost the same as the duration of response to monoagent pembrolizumab, nearly 2 years. And of course, because that's a very high response rate, long duration of response multiplied by very high overall response rate is what's giving us this really quite unprecedented effect seen in the EV302 trial. And then finally, and right up to date, we saw these data just a few weeks ago at the ESMO meeting, and this is the first of 2 randomized phase 3 trials exploring the role of EV and P combination in the perioperative setting. So this is in patients who are undergoing cystectomy as a curative treatment. It's a slightly complicated design, but fundamentally, this is a group of patients who are not suitable for cisplatinum, and so they were randomized to go straight to chemotherapy, straight to cystectomy, followed by observation, or to get 3 cycles of EVP, followed by cystectomy, followed by 6 more cycles of EVP. And so sort of what's called a sandwich treatment. So you're getting preoperative surgery and then post-operative treatment. And these are the results. The primary endpoint is event-free survival at the top there, and you're seeing a 60% reduction in the risk of relapse, basically. But even at this relatively early stage of analysis, we're also seeing a statistically significant 50% reduction in the risk of death, with a pathological complete response rate there of nearly 60%. So these are obviously, this is still the subject of this is not got any marketing authorization anywhere in the world yet, but this might be the first opportunity where we're using new drugs to actually improve the cure rate, at least in bladder cancer. So the call to action here is that chemoimmunotherapy has transformed the initial treatment of advanced urothelial cancer, but there remains an unmet need for treatment on relapse, and enfortumab vedotin is a proven therapy in both the trial and, I believe, the real-world setting. But in the future, antibody-drug conjugates will offer more transformative treatment options in advanced urothelial cancer. So I've prepared some cases to talk a little bit, particularly focusing on toxicity management. Now, I don't know whether we want to go straight into that or whether people want to discuss or ask any questions around the data that I've shown first. I'm very happy to do it either way.
Yes, sir. So we can take some questions.
And show you the cases. So we'll talk. So I've chosen some cases to really particularly to illustrate, trying to illustrate who's suitable for treatments with EV, and a bit about how the practicalities of managing this treatment. So the first case is a patient of mine called Malcolm. He's a fairly typical Glasgow bladder cancer patient. He's 68. He's got a moderately good renal function. He's not diabetic, and that's important for reasons we'll come to. He does drink alcohol quite avidly. He drinks 35 units of alcohol a week. It's not untypical in my country. He's an ex-smoker, ex-heavy smoker. But he's a man who we talked, and he's very particular that actually overall survival isn't the be-all and end-all for him. Actually, what's really important to him is maintaining his quality of life. So he he had a muscle invasive bladder tumor with some squamous differentiation, although it was predominantly urothelial. And he had, at the time of diagnosis, pelvic and thoracic lymph node metastases. It was FGFR wild type. He was treated with 4 cycles of gemcitabine cisplatin for metastatic disease, and then went on to maintenance avelumab, but now has progressive lymph node metastases. He has moderate comorbidities of COPD and hypertension. So the first thing to think about here for me was, well, what are the we've got to make a decision here. What are the patient features? He's asymptomatic. His focus is quality of life. He may not want treatment at all at this stage. He's got lymph node only metastases, and that's generally associated with a relatively good outcome in metastatic disease. It's a relatively good prognostic feature. But he has no prohibitive comorbidities. His bloods, his performance status would all permit me to give any of the available treatments. In terms of his options, I guess based on his profile, then enfortumab vedotin is clearly an option. He's had chemoimmunotherapy. We might want to consider further chemotherapy, such as paclitaxel, which would have been the drug I would have used prior to EV availability. But also I'd want a conversation with this patient about whether best supportive care would actually meet his needs as well. In fact, he chose that he wanted active treatment, so I recommended enfortumab vedotin. And so then it's a matter really of preparing the way. And this is quite an important element, I think, particularly with regards to the key toxicities, the skin toxicities and the neuropathy, because I think it's very important that patients do a degree of self-monitoring. They must report in. Patients don't report in mild rashes, for example, but I think it's important with this drug that they do. And he was obviously specifically advised about the risk of neuropathy, because this is a very common toxicity. Baseline assessment, always do a baseline assessment of nerve function. Don't need to do any fancy tests. It's really just assessing the functional ability, and also specifically check blood glucose, including a hemoglobin A1C. You can see we did that. It was normal in his case. And then I like to see these patients, or at least one of my team, to physically see these patients at every visit before they receive a dose of the drug. I want to look at their skin. I want to check they don't have rashes. And particularly, I want to assess their peripheral nerve function, again at a purely functional level, but in my experience, that you often have a relatively narrow window of opportunity to intervene. So if you don't see these patients at every visit, they may go from having a manageable neuropathy to one which could actually become quite problematic. So anyway, he went on to the treatment. He was doing well. After 3 cycles, we did another scan. You can see there that he had a good response in those mediastinal lymph nodes. And then after 8 cycles, he comes into the room and he's complaining of some numbness in his fingertips and a little bit of unsteadiness walking. And when I examine him, he has some minor sensory neuropathy, and he's struggling to do up his buttons. He struggles picking up a pencil off a flat table. I find is quite a good test, quite a good easy test. He's struggling to do that easily. I assess his gait, and he's not got an obvious balance disorder, but he's struggling with heel-toe walking, and he's quite slow walking in from the waiting room, in fact. So my diagnosis here, he's got a grade 1 gait disturbance and a grade 2 sensory neuropathy because it's symptomatic. That's what makes it grade 2. I won't go through this one by one, but the important things to ask your patients around peripheral neuropathy are about numbness and tingling, although typically in my experience it's numbness that the patients complain of rather than paresthesia, and particularly about difficulties with balance and difficulties with walking, and particularly about any impact it's having on actual daily functioning. And so remember, with peripheral sensory neuropathy, grade 1 is asymptomatic. So unless you're doing detailed neurological examinations, you're unlikely to identify grade 1 peripheral sensory neuropathy. But as soon as it's symptomatic, then it's grade 2. Paresthesia that doesn't interfere with function is grade 1, but fundamentally the toxicity here is loss of sensation. And so if the patient is complaining of loss of sensation, then by definition it's grade 2. And in terms of how you manage this, well, the important point is to intervene at that grade 2 point, i.e. the point where where Malcolm is now, because if it reaches grade 2, you need to withhold the treatment until it settles down to grade 1 again. Then you can restart, but if it recurs, you then need to again interrupt, and at that point dose reduce. But once you get to grade 3, of course, grade 3 is actually quite symptomatic, quite disabling for many patients, and you need to permanently discontinue the treatment then. There are other sort of questions that arise. The first question that often I'm asked is, well, can you use drugs to prevent or to treat peripheral neuropathy? Well, the straight answer to that is there's no drug that's been shown to be effective in preventing it. I think that's an area that's ripe for research, actually, but there's no drug that you can give a patient to prevent them developing the neuropathy. You can use drugs to treat painful peripheral neuropathy, and I have seen painful peripheral neuropathy with enfortumab vedotin, but as I say, by and large, it is not painful. It's usually loss of sensation, and there's no evidence that drugs, nerve-acting drugs like duloxetine or pregabalin or gabapentin, there's no real evidence that they will improve sensation. So in my experience, drugs have a relatively limited value in treating peripheral neuropathy. And the other question is, well, when would you refer it to a neurologist? Because clearly there's nothing that the only person who can actually treat this is the oncologist, by managing his dosing of the enfortumab vedotin. And so actually a neurologist isn't going to have much to offer in this context. At the times I do consider referring to a neurologist would be if I was a bit uncertain as to whether this was actually a drug-induced peripheral neuropathy, if it had abnormal features, for example, particularly if there were other possible causes. For example, in Malcolm's case, he's quite a heavy drinker, or if it's a diabetic, for example. So then I might consider referring to a neurologist. But by and large, it's an easy diagnosis to spot, and it's nearly always drug-related, and you don't need to necessarily consult with a neurologist. Anyway, his update on Malcolm's case, it did recover. It took about 4 weeks to recover to baseline, and he restarted EV, and I went in with a dose reduction straight up in Malcolm's case. So peripheral neuropathy is a disorder characterized by the dysfunction of peripheral sensory, motor, and autonomic nerves. With EV treatment, it is predominantly sensory symptoms, and that's usually in a stocking and glove distribution, because it's the longest nerves in the body that get affected first. And so in the EV301 trial, some grade of peripheral neuropathy was seen in 46% of patients. And it was the most common treatment-related adverse event leading to interruption and withdrawal. But despite that, we still saw these results of the 4-month improvement in median survival. And as I said, unfortunately, preventative strategies and to a degree treatments are still lacking. So we'll move on and talk a little bit about blood sugars and indeed skin. This is a patient, Jill, 72-year-old woman, good renal function, but she's a diabetic. She's a type 2 diabetic. Her hemoglobin A1C is 7.9%, which is at the sort of the upper end of controlled diabetes. She presented 2 years ago with a muscle invasive bladder cancer without metastases. She was treated with neoadjuvant cisplatin gemcitabine and then had a cystectomy. Unfortunately, at cystectomy, she had residual T3 disease, which was PDL1 positive, FGFR wild type. And so she then went on to 12 months of adjuvant nivolumab, which is licensed in the PDL1 population in Europe. And anyway, now she's 6 months after completing her nivolumab, and a routine scan shows that she now has lung metastases, from which she remains asymptomatic. So as I say, she's type 2 diabetic, and like most type 2 diabetics, she's also hypertensive, and she's treated with metformin and gliclazide. She admits she's not been that good at following her diabetic diet, at least since completing her treatment. She needed a bit of time off her diet, I think, was very much how she felt after completing quite a grueling course of cancer treatment. But she is clear that actually survival really is her goal. She's got grandchildren. She wants to see them for as long as she can. So in considering her baseline factors, her eligibility, she has no symptoms. She has diabetes, which is not optimally controlled, and blood sugar disturbance is a side effect of enfortumab vedotin, whereas it's maybe not a side effect of the other treatments we might consider. And her preferences, as I say, survival is her key goal of treatment. So what are the treatments that we might consider for her? Well, obviously, enfortumab vedotin is one of the treatments we might consider. And we might consider chemotherapy. Be interested in your views. Before we had anything else, I think we might well have considered her for re-challenge with platinum-based chemotherapy. Remember, it's 18 months since her cystectomy, because she had 12 months of nivolumab, and so it's actually more than 18 months since she last had platinum-based chemotherapy. Although I would say that she didn't have a very good response to it, because remember, she still had T3 disease at her cystectomy. And as always, best supportive care is an option to consider at this point. And again, particularly maybe in somebody who's asymptomatic. So I guess the first point I'm illustrating here is that there are various pathways by which you become potentially eligible for monoagent enfortumab vedotin, because you have to have had the prior chemotherapy and you have to have the prior immunotherapy, but you can have had those in a variety of contexts. So Jill here is the third line down. She's had neoadjuvant platinum followed by adjuvant nivolumab. But it may be that patients would have had adjuvant platinum followed by immunotherapy for metastatic disease, or as I gather, in India is the most likely scenario. The patient would have had first-line platinum combination for metastatic disease followed by second-line immunotherapy. So these are the scenarios in which you might become suitable for EV. But are there patients who are less suitable for EV? So this was a letter that was published in response to the EV302 data, I think it was. And this was a letter trying to formulate some consensus criteria around who is maybe not suitable for EV. Now, in fact, there was no consensus methodology applied at this stage, but this was the list of criteria that the authors came up with. So firstly, a hemoglobin A1C of greater than 8%, which I think is about 6.2 millimoles per litre. Secondly, a grade 2 or worse sensory or motor neuropathy. any corneal or retinal abnormality, or a creatinine clearance of less than 45, or performance status of more than 2. In fact, there's really very little methodology and almost no evidence used in generating these criteria. I would say, so my view on this is that I don't think we should take these at face value. I would agree. I think if you've got a grade 2 established peripheral neuropathy, then it's going to be very difficult to manage EV, and clearly any deterioration from grade 2 could be catastrophic. So I think that's certainly a group of patients I would want to avoid EV. Any corneal or retinal abnormality, actually, these abnormalities were really quite rare with enfortumab vedotin, and actually nearly always very easily managed and of no great consequence. So, and I don't think there was any evidence that prior corneal or retinal disease is a contraindication to EV. So I wouldn't agree with that. Similarly, creatinine clearance, enfortumab vedotin is not renally cleared, and it's not nephrotoxic. So I see no particular rationale in avoiding this drug in somebody with a low creatinine clearance. I very much disagree with that one. ECOG performance status of 2 or worse. Well, I mean, I think many of these patients are not going to be suitable for any treatment, but I don't think these patients are any less suitable for EV than other treatments, but clearly it has to be an individual patient made decision. And what about the hemoglobin A1C of 8%? Now, Jill's was actually 7.9%, and I didn't, so she wouldn't have quite met this criteria. I think this is potentially quite misleading, because of course hemoglobin A1C of more than 8% reflects that over the past few months diabetic control has not been very good. It doesn't mean it can't be made good. And so actually I think focusing on HbA1c is probably missing the point. The focus really should be on blood sugar now and optimizing control of it. And so actually many patients with a hemoglobin A1c of greater than 8%, whilst I would agree that patient has poorly controlled diabetes, you have an opportunity to get the diabetes under control, and therefore the patient becomes suitable for the treatment. So the EVITA criteria were kind of put to the test through a questionnaire survey of experts, and actually this is what they came up with. So they did agree that this, as do I, that peripheral sensory neuropathy would be a contraindication to EV in most cases. But note the performance status here, the threshold is now set at 3 rather than 2. And I would agree. I think a patient with a performance status of 3 is unlikely to benefit from systemic anti-cancer therapy, full stop. So whilst I wouldn't offer this patient EV, I wouldn't be offering them anything else either. And you can see that all the other criteria didn't really meet any form of consensus, less than half the experts agreeing with those. So I think the EVITA criteria were poorly conceived and probably not representative of experience or expert view. And there was this concern raised about the non-urothelial component, but actually I think the UNITE data actually answer that question for us. So although the experts here were concerned about non-urothelial component, patients with a component seem to benefit. Although I would agree that if it's a pure histology, we don't really have a small cell histology, for example, we don't really have the data to support using EV there. So Jill, so for her, I think that EV remains the most attractive option. Her disease, her diabetic control, so her cancer control, her disease, her cancer is relatively indolent. So we do have time in her case to get her diabetic control better. She admits that she's not been very compliant with her diet, for example. So actually with a bit of time and maybe here a bit of help from an endocrinologist, we could get her blood sugar much better under control, and she would then be quite suitable for EV. So you do nonetheless see hyperglycemia with EV, but in my experience, it usually settles it's usually a very transient effect. And so this can usually be easily managed, occasionally requiring a dose delay if the patient's blood sugar is high on the day of treatment. But if you can delay it and allow the blood sugar to drop, the blood sugar, not the HbA1c, then the treatment can go ahead. The ocular disorders are rare and largely manageable. I give all my patients artificial tears with their first prescription and advise them to use them at the first opportunity. Sometimes it's good to advise patients maybe to avoid using contact lenses, for example, which may worsen the risk of corneal toxicity. Anyway, so Jill went ahead with treatment, and then on cycle 2, day 1, so this is 5 weeks into treatment, she presents with a non-painful, non-itchy rash on her forearms. And you can see there's a macular-papular rash, in this case, very typical of a drug eruption. So these are common. In a grouped analysis of patients in various EV trials, we're seeing 55% have a skin reaction, although high-grade skin reactions are relatively rarer, 1 in 8 patients having a higher-grade skin reaction. Alopecia is very common. But it's these macular papular rashes rather, which are common, often in the intertriginous regions. You can see under the in the armpit here, between the legs, for example. So that's a common place, and I will always look in patients in these creases in patients when they come up to check they haven't got rashes here. Blistering lesions are something we need to be particularly on the lookout for, and I'll come to that shortly. So the important thing here is you're asking your patients to report skin toxicity, and you're looking at the skin and monitoring for this. I think some simple advice like avoiding sun exposure where possible. That's not difficult in my country. I suspect it's a lot more difficult in India. Regular moisturizing, avoid impregnated moisturizers because they can be irritant. When skin rashes do occur, often they respond well to topical steroids. I don't use steroids in asymptomatic rashes because really the benefit of it is to settle the symptoms, and if it's asymptomatic, I'd largely ignore it, to be honest. But patients who've got an itch, steroid creams, even steroid ointments often allow you to get a higher exposure to the topical steroids, and they can be really quite effective. If you get a grade 3 rash, then you need to withhold and let it settle down. Often in this case, I would be treating with creams with topical steroids. And if you do unlucky enough to get a grade 4 or a recurrent grade 3 event, then you're probably going to need to permanently discontinue EV. And of course, the concern here is around these rare instances of very severe cutaneous reactions, in particular toxic epidermal necrolysis or Stevens-Johnson syndrome, which has been reported with this drug. It is very rare, but of course it can be fatal when it does occur. And that there are some warning signs you need to look out for. So particularly if you're getting skin exfoliation, as on the left here, or on this patient's back, or if you're getting big blisters, bullous type blisters, these are warning signs in the skin, and these patients really need to be referred immediately to dermatology and withhold the drug. Other features are painful erythema, mucosal involvement, or presence of systemic unwellness, particularly fever. These are all red flag signs that this patient may have a more severe reaction going on, and may need, almost certainly does need, immediate dermatological expert advice. So as I say, these patients you really need to manage quickly, and that's why these patients need to report in with their rashes, because this can very rapidly progress to, as I say, life-threatening skin toxicity. And then finally, a question I often get asked is about dose. Given the incidence of these toxicities, the low-grade skin reactions, and the neuropathy, actually, should we start patients at a lower dose or maybe use a slightly less intensive dosing schedule? Well, I think the straight answer to that is no, I don't think we should. These are data, in fact, from one of the phase 2 trials of EV. And you can see all the patients started at the full dose, which is 1.25 milligrams per meter squared. You can see that dose reductions are quite common, and you can keep patients on treatment with dose reductions, but there are quite a few patients who never have a dose reduction as well. So there is a risk that if we don't start everybody at the full dose, we may well end up significantly underdosing patients, and you may be compromising activity. And there's a bit of evidence to support that. This is from the 301 trial. This is looking at, actually, it says dose. It's actually about pharmacokinetic exposure. And so if you simply look at the pharmacokinetics and divide the patients into quartiles, the ones who have the highest exposure to the drug are more likely to respond. Not a big surprise, but there is a clear relationship between exposure and activity of the drug, and therefore there is a clear relationship between dose and activity to the drug. So we really should not be underdosing patients. So all patients have to start at the full dose, but you have because you're seeing the patient every week initially, you have the opportunity to dose reduce as soon as the patient starts to run into problems with toxicity. So the key message is patients who've received platinum and immunotherapy in a variety of settings may be candidates for EV. I think there are very few total contraindications to EV, and the toxicity, although it is different from other drugs we have used, I don't think it's worse. It's just different, and these toxicities can be managed. And it's simply a matter of us learning new tricks. And of course, as oncologists, that's what we're brought up to do. We come into oncology because we like novelty, because treatments are evolving all the time. Just a couple more photos of my beautiful country, Scotland, to tempt you to come and visit sometime. But thank you very much. I'll stop sharing my screen so maybe we can see each other.
So thank you, Dr. Jones, for such a detailed and nice discussion on this new molecule. And now we will proceed to a panel discussion. But I think you have covered many of the aspects that we are going to discuss in this panel discussion. So can you see my slides?
I can, yes.
Yes, we'll start. So Dr. Jones has nicely discussed about how the treatment landscape of urothelial cancer has evolved in last 2 to 3 decades, starting from MVAC to GEMSIS and so on. And then comes the role of immunotherapy, especially Nivo, Atezo, Pembro, and then comes the role of EV. And from here, we will go forward and we will be having a small panel discussion. And I request Dr. Rajesh, Dr. Akash, and Dr. Satwik, and obviously Dr. Jones to present here. And so my first question is to Dr. Jones. Sir, you discussed about this molecule, about the EV, the role in second line setting, the role in first line setting, and there is not only the PFS, there is also the OS benefit with this drug. So what is your experience with the other histology apart from transitional cell carcinoma? Does this data apply to other histology also? What is your experience?
So I'm not permitted to use. So obviously there's two concepts here, aren't there? There's patients with variant histology, whether it's urothelial cancer, but it's differentiated. Yes. And those patients were allowed into the trial, and those patients were allowed into that UNITE real world data set. And so the commonest I see is urothelial cancer with squamous differentiation. And then, of course, within that, there are also subtypes of urothelial cancer, many of which are very aggressive, like micropapillary disease. But fundamentally, these are all urothelial cancers. And so all of these patients I would and do give enfortumab vedotin to. I think a lot of them are. So it's like micropapillary disease, unfortunately, is a poor prognostic factor, but it's not a predictive factor. In fact, if anything, my experience is that those patients actually respond better to drug therapies. I can't say specifically to EV. So those patients would. But then there's a second group of patients who actually have a different cancer. It's not urothelial cancer. It's come from a different cell type. So I'm thinking about adenocarcinomas, urachal carcinomas, and of course, small cell and neuroendocrine tumors. And they're not generally differentiation features. These are not urothelial cancers, they're other pathologies. I have no experience. I'm not permitted to use the drug in those contexts, but also I'm not aware of any significant data sets in those groups. So I wouldn't use it, but it's a different disease fundamentally.
Yeah, so the one thing is very clear that before using this drug, one has to be very confident that they are dealing with transitional cell carcinoma. So Dr. Rajesh, so we are basically will be discussing about the second line therapy that are available to us. So before going to the second line, in your clinical practice, what are the options that you have for the first line setting? And what is your experience with chemo plus IO, or chemo followed by IO maintenance? How you go, how you decide your treatment in the first line setting, Dr. Rajesh?
So in my patients in first line setting, we have options of EV with Pembro. We have option of Nivo with chemo followed by Nivo, and James is followed by Avelumab maintenance. And many times I end up giving only chemotherapy because of financial constraint. So among these 4 or 5 options, I have to choose this patient in a first line setting. Though EB and Pembro I have never used, they still we have not got DGCI approval, but the data is very
Yes,
data
data is
is
impressive.
data is impressive, and also NCCN guidelines and most of the guidelines now they have taken it as only category 1 recommendation. Then others are they have taken in alternative options. So I think that in future I'll be happy to use EV and Pembro in first line setting.
So, Dr. Akash, like as in India, as we know that most of the patient will be paying for the drug from the out of pocket, rather than in the other Western world where they will be paid by the insurance company or for that matter by the government. In India, unfortunately, patient has to pay from the pocket. So, do you think that financial constraint is a big hindrance to use the newer molecule, not only the EV, but also even immunotherapy? Dr. Akash.
Undoubtedly, sir, undoubtedly. So, in real life, I think that remains the biggest hindrance of this, rather than cost evidence. The logistics may be.
Correct. So, Dr. Satvik, like we have used all type of combination that has been approved with chemo or chemo IO. And so, in the first line setting, what is your go-to regimen if money is not an issue? And basically, how you choose between the IO maintenance and the chemo IO? So, basically, chemo nivo or chemo followed by available maintenance. We have a two option if you choose IO. So first Dr. Satvik and then Dr. Jones between the two. Dr. Satvik or Dr. Jones, can you take this question between the Nivo chemo versus available maintenance, the two different approach? Any predictive marker where we can choose one over the other?
So, I mean, the straight answer to that question is there's no good way of guiding between these treatments. I think there are other significant factors, though, that are relatively easy to deal with. So remember the Checkmate 901 trial, which was the chemo Nivo trial, was only for cisplatin eligible patients. So actually, I would not consider giving it to a patient I'm not going to give cisplatinum to. At a very practical level, actually, cisgem Nivo is not licensed in Europe, so I'm not using it in that combination. if we look at the trial data, can we easily see which is the best? No, you can't, I don't think. I think it's very difficult to make any form of inter-trial comparison because, of course, you may argue that on paper, the patients getting the maintenance of avelumab look like they've got better outcomes in the trial. Remember, you had to have had a response to cisgem to enter the
Yes,
Javelin 100 trial,
very true.
whereas of course it was all comers going in to the cisgem trial. So in other words, there's a third of patients, the bad players, who were in the 901 trial, but were not in the Javelin 100 trial. Conversely, the Javelin trial had the carboplatin patients as well, and we know that those patients have a worse outcome. So it's almost impossible to make any form of comparison between the trials. But I think you can justify either. I guess the other factor that's a difference between them is, the dosing regimen for avelumab is given 2 weekly. Nivolumab can be given 4 weekly.
Yes.
And that may be quite a significant factor. And indeed, in an environment like your own, where the patients are paying out of pocket, I don't know what the relative costs of these treatments might be, but that might be a factor. So I think you could use either, and it's those other factors you'd have to choose. Is there a predictive marker? Well, I mean, the straight answer to that is no. I mean, I don't think PD-L1 has been a helpful marker at all, really, in bladder cancer. And so I certainly don't think it can help distinguish between one immunotherapy and another.
And Dr. Jones, second part of this same question, like if you see the other malignancy like ovary or lung, there is not a much difference whether you use carboplatin or cisplatin. But when it comes to urinary bladder, cisplatin scores over carboplatin. Do you agree that whenever possible, cisplatin is the go-to drug rather than carboplatin in urinary bladder?
Yes, I do. I mean, of course, there has never been a randomized trial comparing cisplatin with carboplatin in the cisplatin eligible population. So we don't know the answer to that question absolutely. And there have been various attempts which come out with slightly differing answers to make indirect comparisons. But we have to go with the evidence we have, which is that cisplatin is that if the patient's suitable for cisplatin, they should get it. The other thing I would say is that, in 20 years ago, cisplatin was a much tougher drug than it is today, because
Yes.
actually the antiemetic treatments have got so much better. I mean, I don't know what you use, but I use a prepitant as an antiemetic with cisplatin. And since we've been using a prepitant, I pretty confidently tell patients you're not going to be sick with this treatment. 20 years ago, you'd be confidently telling them they would be sick with it. So actually, I'm not sure that cisplatin is that much harder a drug to give or receive than carboplatin. So I have a very high threshold for using carboplatin, actually.
Okay. So, Dr. Rajesh, so this is about the brief discussion about the first line setting. But as we know that most of our patients will end up receiving platinum plus gemcitabine. In the first line setting, very few patients receive the immunotherapy in the first line. But unfortunately, patient will progress on platinum doublet. So what are the second line option you have once a patient progressed on the chemotherapy of gemcitabine, cisplatin or gemcitabine or carboplatin?
So, as discussed today, the treatment options which are available in second line, classically we used to give chemotherapy like paclitaxels, but now we have EV or immunotherapy in second and subsequent lines of therapy. So, if patient is affordable, then yes, we should choose EV in a second line.
So, Dr. Satvik, like if we compare EV versus immunotherapy, how will you choose? Do you have any parameter, any platinum resistance or platinum sensitivity? What parameter you want to see to choose between immunotherapy or EV? Dr. Satvik, are you there?
Yeah, I'm there.
Yes.
Okay, so between chemotherapy and immunotherapy, you're asking. So, patient fitness is
No,
one thing.
between immunotherapy and EV, infertumab vedotin.
So if somebody has already received, let's say, patient was on avelumab maintenance or had taken single agent pembro in the first line, then obviously I would avoid immunotherapy. I would avoid switching immunotherapies. I would prefer EV in these kind of patients. Other than that, patients who had autoimmune disease, active autoimmune disease, or in some patients who had contraindications to immunotherapy for some or the other reason, I would prefer EV in such kind of patients.
So Dr. Jones, do we have any data comparing immunotherapy with EV in the second line setting?
I not that I can think of. I think nearly all of the work that's been done with EV has been either in combination with immunotherapy or after failure of immunotherapy.
Yes.
I mean, rationally, the response rates to monoagent, you saw the response rate there was 40%. It would presumably have been similar if you'd given it to a group of patients who are immunotherapy naive. But I guess the thing about immunotherapy, the first thing is that all the evidence for EV is on the basis of the patient already having had immunotherapy or is going to have it at the same time.
Yes.
So there's no strong rationale. I mean, I guess the other thing is, I think immunotherapy. I always say that if you're going to have metastatic bladder cancer, you want to be the patient who responds to immunotherapy, because those are the ones who have the really good outcomes. The problem is we've no way of identifying who they are. So actually, it's really important that everybody who can get to try immunotherapy. So I think I think if you can give immunotherapy, I would give that as a priority to a patient who's never had immunotherapy before.
So Dr. Jones, will you see between the concept of platinum sensitivity before choosing IO versus EV? Because ultimately EV also contains chemotherapy. So assume you have a patient who has received 6 cycles of gemcitabine cisplatin and progressed within 3 months of completion of this chemotherapy. Do you think in this subset of patient where patient has progressed so early, so fast on chemotherapy, these patients may be candidate for immunotherapy rather than EV, or it is other way around? I just want to know your opinion.
So, I mean, I don't know. I mean, that patient, fortunately, if they fail rapidly, those patients are going to do relatively poorly, however you treat them, unfortunately. But again, there's really no evidence for giving EV in a patient who's never had immunotherapy. So I think still the standard of care there is, if that patient is immunotherapy naive, they've never had it in any context, I still think that's probably the treatment of choice. I mean, I guess the one sort of group of patients, if rapid progression, if your priority is to get the disease under control, okay, if you really need to get a response, and that's quite an unusual scenario, but if getting a response is your primary goal, we know that response rates with the monoagent immunotherapy are low, less than 20%. Whereas, as I said before, probably the response rate with EV is going to be high, but it would be an unlicensed use of EV. But I guess if you want to say, well, what's the thing that's most likely to get this patient a response? Probably EV would be the drug that would do that. But that's a pretty unusual scenario.
Yes. So we'll start with 1 or 2 simple cases before we end. That a female patient of 78 years, PS of 1, with BMI of 32, and there is a history of unresectable locally advanced urinary bladder cancer at the time of diagnosis. She received the typical standard of care with GM-CIS, avelumab, switch maintenance, and disease spread to now abdominal wall. In comorbidities, she has diabetes, fatty liver, and moderate renal impairment with a creatinine clearance of 34 ml per minute, and she is taking metformin. So Dr. Rajesh, for this given of patient, although she is 78, but again you can see the ECOG performance status is 1. What are the options? How will you proceed? Patient has already received on gemcitabine and cisplatin followed by avelumab maintenance. I don't know what is the disease-free interval this patient. I assume there is patient received avelumab maintenance for 8 months and now there is a progression. How will you
So decision will be like, we have to discuss with the patient what she want, and we'll give options of enfortumab vedotin if she wants. She is willing to increase her lifespan. And she has already received immunotherapy. So among available option, I will prefer to use enfortumab vedotin.
So, Dr. Akash, what are the prerequisite test or clinical information you want to ask from the patient, or you want to perform some test on the patient before making sure that patient is eligible for EV? So, like if this patient agreed to receive the EV in the second line setting, what is the important clinical information or any investigation you want to ask for, Dr. Akash? Or Dr. Satvik, you can also take this question.
Sorry. Yeah, so I would like to check the diabetic status of the patient.
Yes.
Underlying any peripheral neuropathy is there because of diabetes or some other kind of comorbidities. So these two, then ocular examination, I would obviously get a ophthal clearance to see any underlying unnoticed or undiagnosed ophthalmological comorbidities. So these are some things which I would be very aware before starting EV.
Correct. So the controlled diabetes, the ocular, the peripheral neuropathy, because many of these patients have diabetes. So diabetes neuropathy can be an important, the side effect of this drug also. So Dr. Jones, like if this patient is for EV, apart from the what Dr. Satvik has mentioned, so do it really important that given a set of patient who received immunotherapy in the background, or the patient who is immunotherapy neo, whether the response to chemo, the efficacy of EV, it really doesn't it really matters that if patient whether has received IO before EV or IO neo.
I'm not quite sure I followed the question. So, as I
So,
said,
yeah, so basically, if you have two patients, one patient has received only chemotherapy and now
Yeah.
going to EV, another patient who has received chemotherapy and followed by available maintenance, and now patient has progressed, and this patient also want to receive EV. So, in between these two patients, one patient is exposed to immunotherapy and one patient who has not exposed to immunotherapy. Do you think the efficacy of EV matters based on the prior exposure to immunotherapy?
So, I mean, straight answer to your question is, do I think that prior immunotherapy in some way primes the patient to respond to EV? No, there's no I can think of no
Right.
hypothesis for that. But EV is only licensed for patients who previously had
Yes.
immunotherapy, and that's because that is where the evidence lies. So actually, a patient like this who's had chemo with maintenance of avelumab, this is the main, in my practice, this is the mainstay of patients who are getting EV. And actually, because they're on maintenance treatment, you're actually detecting these patients quite early on when they progress. So you can get most of these patients onto the EV whilst they're still fit enough to receive it as well. So yeah, I would really stick with the use of EV for patients who've had the immunotherapy before.
And how common is the infusion reaction hypersensitivity with EV? Because I think among all the panelists, you are the one who has used this molecule in the maximum patients. So I just wanted to know what is the percentage of patient who develop hypersensitivity and of what grade? Like, what is your experience?
So my experience, I have never seen it actually.
Never seen. Yes.
There was a figure, I think, on one of the. I can't actually remember the exact figure because it does happen, but it is pretty rare. I mean, I guess I'm guessing it's probably the antibody. Most monoclonal antibodies have an incidence of infusion reactions, don't they? But I have to say, I'm just trying to remember. Can't remember a patient who's ever had a significant infusion reaction, at least.
Yes.
I've never been
So
able to
like, so it is very rare. So it is very rare.
Yeah, in my experience, as I say, it's rare. But you know, it does happen.
And any pre-medication that you use before giving EV?
Not routinely. If somebody
No.
had a reaction, then I would pre-medicate for further treatments.
Okay.
Yes.
Otherwise, in a normal patient, there is no need to use any pre-medication.
No.
No. So, Dr. Rajesh, the two important organ is renal dysfunction and hepatic impairment, and it is not uncommon to find renal dysfunction or hepatic impairment in an elderly population, because we know that the urinary bladder is a disease of elderly population. So what do you do if patient has renal dysfunction? What is the cutoff of giving EV? How you want to proceed if patient has deranged renal dysfunction, Dr. Rajesh?
So I don't have experience of using EV in renal impaired patient, but I was listening to Dr. Jones. He said that renal impairment is not a contraindication to use EV. So I will remember it and I will use even at least I will give a chance to use this drug in even a patient who is having renal impairment.
So Dr. Jones, do we have any cutoff of the GFR 45? I think you mentioned.
I think I'd have to check to go back and look at the trial protocols, but I think the cutoff in the trial was 30. I mean, I have to say that in somebody who's got a really, really severe renal impairment, that actually, your question is my question for that patient is that actually probably the more urgent priority is trying to improve that patient's renal function rather than trying to treat their cancer, to be honest with you. So I think, yeah, I have in my sort of practice, I have a sort of cutoff of around 25. If it's below 25, you're going to really struggle to effectively treat that patient, because actually the renal function itself is associated with a very poor outlook. And so you really got to be asking the question, actually, if I'm not going to correct or can't correct this patient's renal function, am I really doing them any favors by treating their cancer? I'm going to have to say that's how I look at this situation. As I said, EV's not renally cleared, but it's not been studied at patients with really low renal clearances. And as I say, those patients tend to have a really poor prognosis anyway. So I think that's a patient you need to have a serious conversation with about best supportive care as an alternative, to be honest.
And I think one of the important learning from Dr. John's lecture is that the presence of diabetes is not a contraindication to use EV. We can very well control the diabetes and then put the patient on EV. And we will go to the second case and see, for the same patient started on EV. Diabetes has remained controlled with regular monitoring with blood glucose. And she has grade 1 neuropathy, sensory neuropathy. And Dr. Jones discussed in details about the neuropathy, how to deal with that, the role of duloxetine. But again, difficult to treat, and also when to refer a patient to the neurologist. But I totally agree what he suggested, that it is important to decrease the dose and also to stop whenever needed, rather than causing a permanent neuropathy, because treating neuropathy is really a nightmare. Dr. Jones, how common is the neuropathy, and do you think that it is better to prevent than the treat when it comes to neuropathy?
So the answer for the second bit, yes, if we could prevent it, clearly that would be the ideal scenario. But we can't prevent it. The only way you can prevent it is by not giving the drug at all. So we can't prevent it. So it is about managing it. And it's about managing it rather than treating it as well. As I say, you can't really, there's nothing you can do once it's occurred to reverse it. Only time will reverse it. And it does tend to recover with time. And I've had people go, actually, unfortunately, quite high-grade neuropathy, which has resolved to baseline over time. So it's really about dose management is much more important. You asked how common it is. Well, in the trial, it was nearly half the patients had peripheral neuropathy. I suspect, and actually, if you look at the EV302 trial, where, of course, patients survived longer, and so were potentially on treatment for longer, it's not so much the higher incidence, but actually, if you look at patients who then end up with dose interruptions, is really very high indeed. So it's a cumulative toxicity. So that what that means is that Nobody gets it after the first dose or two. So again, no value in reducing the dose. But probably most patients will get it if they're on it for long enough. But nonetheless, the benefits still accrue because in the trials that showed the benefits, the doses were modified or interrupted for the neuropathy. But it is very common. And that's why it's so important to monitor it, because your job, our job as doctors, is managing the dosing when it does occur.
Yes, so Dr. Jones, as you suggested, this is a cumulative toxicity, dose-dependent toxicity. So, is this a good idea to give some doses of EV, and then when there is a neuropathy, we give some drug holiday, drug interruption, and once the severity of the neuropathy decreases, and then we can again restart the EV with the same dose or maybe one dose reduction. So, I think is this the way to go?
Yes, exactly. Yeah. And if you really want to avoid it going to grade 2, if you possibly can, because once you get to grade 2, the recovery times are then so long. You're almost certainly going to keep the patient on drug for longer if you interrupt and manage the dose when it gets to you don't want to get into grade 3. So when it gets to grade 2, if you can intervene when it gets to grade 2, that's the real key to this. You don't want to see grade, you want to avoid seeing grade 3 neuropathy.
And as far as ocular side effect, you have mentioned that they are also very rare, not common, and some important measures to use artificial TRS spectacles and consider referral wherever there is ocular symptom. So, have you ever come across any patient who has developed ocular symptom in your clinical practice?
So the dry eyes is quite common.
Dry eyes is very common.
But it's rarely problematic, and it's one of those things that patients manage with eye drops, and it doesn't seem to be associated with it's not the first sign of more severe eye toxicity either. It's standalone. And yes, there are reported higher grade other ocular toxicities. I've actually never seen those, and they're really not that common. You don't need all these patients to see ophthalmologists. Some of the drugs and some of the other antibody drug conjugates actually are associated with quite severe eye toxicity, and you would probably want to get those patients checked before. Or similarly with erdafitinib, if you remember, there's that rather strange, very separate eye toxicity. So you actually need a collaborative approach with an ophthalmologist with those drugs. You don't need you probably will not need an ophthalmologist.
So basically, treating a cancer patient is not a one-man's job. It is a team. You require a team of different specialists to give the optimal care to our patients. So, in the interest of time, I will not go to the second case. I will just skip this. And one thing I would like to ask Dr. Jones, you also mentioned about the skin toxicity, and you suggested that 1/3 of patient might have skin toxicity, but they remain in less than 1/3 of the area of the body is involved, and Steven Johnson type of reaction are very rare. So, do we use to something in the prophylaxis, or we need to treat whenever they happens?
So I mean, it makes sense to prime patients. I don't think there's any evidence actually that there's no randomized trial of prophylaxis, but things like keeping your skin moist, avoiding sun exposure, avoiding heavily perfumed, heavily chemicaled skin emollients. It just makes sense to do that. But actually, the most important thing is to make sure patients look at their skin and report when they're getting skin toxicities, because patients don't do that. They
Yes.
rashes are quite common in everyday life. People don't associate it necessarily with the drug they're on.
Correct. So we need to educate the patient that you have developed any rashes. Please make sure that you inform to the physician, and this drug can cause skin lesions. So this is the grade. They have mentioned the grade 1, grade 2, and grade 3, and depending on the grade, we need to act. And this case we have not discussed, so I will not go into the detail. But again, coming to the quality of life, Dr. Rajesh, like all the newer molecule that we are using, the ADC we are using in breast cancer, Hodgkin's lymphoma, and so on. Almost every disease has 2 to 3 ADC has been approved. So, what is your experience with the use of ADC? For that matter, you have TDXD in the breast cancer, you have poly-V in the DLBCL, and almost every disease, 1 or 2 ADCs are coming. So, what is your experience in toto with the use of ADC? For that matter, even TDM1 is also one of the
So
ADC.
these antibody drug conjugates in various cancers, they have shown efficacy, but at the same time, they have their own toxicity. So I think it is, and some of the toxicities are dose limiting. I have much more experience of TDXD rather than EV, but yeah, this many a time I have to interrupt the dose. I have to stop the drug, and some patients I have to discontinue permanently. So these are the drug which contains both chemotherapy and this targeted therapy. So they have a side effects of the drugs. We have to monitor it.
Correct. So, Dr. Satak, it will not be a good idea to give ADC and say that it is chemo-free.
Definitely not a good idea. And we should always counsel the patients that although the side effects could be, the acute side effects could be lower than the chemotherapy, but they have their own special side effects which we should be aware of.
Correct. Dr. Jones, any last comment from you?
I no, I guess the comment I would make is that I think that before the EV301 trial, whilst we did use chemotherapy, I only used, it was never, there was never high level data. And now we do have high level data, a randomized phase 3 trial with a clear overall survival advantage. So to my mind, actually, I would, if it can use EV, I would never use taxanes or vinflunine because, it's very clearly shown in a direct comparison that EV is superior to something that was never really proven to work in the first place. So I think it really does become, with the exception of erdafitinib for the subgroup of, the 20% of patients with FGFR inhibitors, it's really the only treatment out there in that post-IO, post-platinum setting that's really got the weight of evidence to make it a standard of care. So if you can access it, it kind of has to be part of your armamentarium here.
So I think we can stop with this, and I would like to thank Dr. Jones for this insightful lecture. We have learned a lot, although we have, at least personally, I have not used this molecule. But again, your lecture, your discussion has primed us that how well should we should be prepared to use this drug. And I'm sure that we will be able to call you for some academic activity very soon. Thank you so much for joining us, sir.
It'd be a great pleasure. Thank you very much. And
Thank you.
I can't say, but enjoy the rest of your meeting today as well.
Thank you, sir. So over to the team Horizon.
Thank you so much, sir, for this webinar.
So I don't know if there is any question. No. So there is no question. So thank you. Thank you everyone for joining. Tata, bye-bye.
Thank you.